Capnography is the newest vital sign. This training will include basic components of capnography. However, we will not do a deep dive into the various waveforms and the pathophysiology behind them. At the end of the course, you should be able to discuss the history of capnography in general and in EMS, ventilation versus respiration, the phases of the normal capnography waveform, and correlate them to the phases of ventilation. We'll also review the cardiopulmonary system. You'll be able to identify a hypoventilation capnographic waveform, a hyperventilation capnographic waveform, a bronchospastic capnographic waveform, and explain the physiologic basis for the waveform's appearance. And you'll be able to list possible reasons for the absence of a capnographic waveform. You'll also be able to discuss when to use capnography in the intubated and non-intubated patients. Identify possible future applications for capnography. At the end of the presentation, we'll analyze some case studies and discuss how capnography impacts patient assessment and treatment. Would you be worried if I told you a patient had a heart rate of 140? What if I showed you this? Think about these examples. In your car, you put in the fuel. The fuel runs the engine. After the engine uses the fuel to do its work, it gives off exhaust. Our body works in a similar way. The fuel is oxygen and glucose. The engine is our heart and cardiovascular system. And the exhaust is carbon dioxide, or CO2. The cardiovascular system consists of the heart, blood, and blood vessels. The heart pumps the blood throughout the body through a system of blood vessels. The blood comes out of the heart in arteries and goes back to the heart in veins. The respiratory system brings in air from outside the body. The air makes its way to the alveoli. In the alveoli, the oxygen diffuses from the alveoli into the blood plasma and then onto the hemoglobin for transport around the body. After the body's cells use the oxygen to do their work, it produces waste, mostly carbon dioxide or CO2, makes its way from the cell back into the blood and hemoglobin and returns to the lungs for exhalation. It is here that with an end-tidal CO2 detector, we can measure the amount of CO2 that is being exhaled. This information can then be used to evaluate the metabolism of the body. The upper airways consist of everything from the nose and mouth to the larynx. The upper airways have a variety of functions, including heating and cooling of inspired gases, filtering, humidification, sense of smell, and producing sound and ventilation. The lower airway begins at the larynx and continues to the alveoli. The lower airway conducts gases in and out of the lungs and enables respiration. Once air is in the alveoli, molecules of oxygen diffuse across the alveolar membrane onto small blood vessels called capillaries. The oxygen travels into the blood plasma and attaches itself to hemoglobin on red blood cells. At the same time, CO2 is released from the hemoglobin into the plasma, then across the alveolar membrane and is exhaled. There is often confusion between the terms ventilation and respiration. Ventilation is mechanical. It moves air with a mixture of atmospheric gases in and out of the lungs. Respiration is physiologic. Respiration consists of external and internal respiration. External respiration is movement of gases between the alveoli and the blood. Internal respiration, or sometimes called cellular respiration, is the movement of gases between the blood and the cells of the body. In cellular respiration, glucose and oxygen are transported to the cell. The cell uses this glucose and oxygen through a complex process of chemical reactions and produces energy and byproducts of carbon dioxide and water. This process is also called aerobic metabolism. As in the example earlier with the vehicle engine, the cell produces waste products, mostly carbon dioxide and water. Through another complex process of gas transport, the carbon dioxide and water are eliminated from the body through exhalation and other body processes. Most of the carbon dioxide is excreted through the lungs. With end-tidal CO2 detection devices, we can measure that amount of carbon dioxide. Through measurement of end-tidal CO2, we can make assumptions about ventilation, metabolism, and perfusion, which are all interrelated. With these assumptions, we can make diagnostic decisions that improve patient care. Monitors and machines assist with patient assessment, but keep in mind they do not replace eyes-on, hands-on care. They are just one piece of clinical judgment. They all have pitfalls, malfunctions, and limitations, and they are all more complex than ever. Remember to always treat your patient, not the machine. Capnography use goes back to the 1970s by anesthesiologists in surgery. Capnography became the standard of care in the OR in 1991. Today, capnography is the hospital accreditation standard in the OR and for procedural sedation. Capnography in EMS is no longer new. In Indiana, waveform capnography is a BLS skill. EMS began to monitor oxygenation with the use of pulse oximetry. Pulse oximetry measures the density of red blood cells. In low perfusion states, the pulse oximeter may not be able to detect red blood cells or may be inaccurate. Even when it does detect red blood cells, there is often a lag time of several minutes. Capnography measures respiration. It began as a colorimetric indicator for intubated patients. Carbon dioxide is a weak acid. Colorimetric detectors use litmus paper that changes color based on the amount of acid that is being exhaled. The colorimetric indicator evolved into qualitative measurement and waveforms for intubated patients. Technology continued to improve so capnography could be used on non-intubated patients. Colorimetric devices are specially treated litmus paper that changes color based on the amount of acid or CO2 that is being detected. However, these devices have limitations. They are for intubated patients only, as the disposable detector fits on the ET tube. They are designed for single patient use. They are easily impaired by moisture or secretions, and false negatives are common during cardiac arrest. Capnometry gives a numerical value of the end-tidal CO2 for both intubated and non-intubated patients. It can be used for continuous monitoring. However, there is no waveform of end-tidal CO2 in the airways. It's similar to monitoring a heart rate in a cardiac patient without seeing an ECG rhythm. Capnography gives the clinician a numerical value of the end-tidal CO2 and a waveform of the CO2 present in the airway. It can be used for both intubated and non-intubated patients. Capnography provides continuous breath-to-breath monitoring similar to a continuous ECG monitoring in cardiac patients. Technology has improved since the early capnography devices. In the 1980s, the devices required up to 200 milliliters of air to get a sample. In the 1990s, new technology was developed specifically for intubated patients. It provided a sensor on the hub of the ET tube and was integrated into many ECG monitors. In the 2000s, as technology improved, only 50 milliliters of air is required for sampling. So let's review some capnographic terminology. Capnography is the continuous analysis and recording. Capnometry is a numeric reading of CO2. A capnograph is a numeric reading and a waveform of CO2. And a capnometer is a device used to measure end-tidal CO2. The capnographic waveform has 4 phases. In phase 1, the baseline is the beginning of exhalation. As the exhalation increases in phase 2, there is a sharp rise in the amount of CO2 being exhaled. Phase 3 is also called the alveolar plateau. This is where the sharp rise of phase 2 ends and begins to plateau and level off. The end of this alveolar plateau, indicated by the letter D, is the amount measured as the end-tidal CO2. Phase 4 is the descending phase and is where inhalation takes place. At the end of phase 4, the waveform returns to baseline. A normal waveform looks similar to the picture. The normal range for end-tidal CO2 is 35 to 45 millimeters of mercury. As you look at the waveform, the distance across the bottom indicates time. So if a patient is breathing very fast, you will see more waveforms. If they are breathing slower, you will see fewer waveforms. The left axis indicates the amount of CO2 measured in millimeters of mercury. The absence of a waveform can indicate a number of things. These may include apnea, a complete absence of ventilation, exsanguination, total airway blockage, a massive pulmonary embolus, or machine failure. There is usually an inverse relationship between respiratory rate and the amount of end-tidal CO2. As the respiratory rate rises into abnormal ranges, the end-tidal CO2 will decrease. Compare the normal waveform to the hyperventilation waveform. As respiratory rate increases, the body will retain carbon dioxide. The result of the capnography is more waveforms, but less than normal carbon dioxide exhaled. There are also disease processes that can cause decreased amounts of carbon dioxide to be exhaled. These include hypothermia, reduced cardiac output, hypotension, and hypovolemia. As respiratory rate decreases to an abnormal range, there will be a corresponding increase in end-tidal CO2. Compare the normal waveforms and hypoventilation waveforms. As respiratory rate decreases, the body will attempt to rid itself of excess carbon dioxide. There are also disease processes that can cause increased levels of carbon dioxide, such as fever, increased sodium bicarbonate levels, or a tourniquet release. Comparing these basic waveforms together, you can see the difference in respiratory rate and the amount of CO2 that is exhaled. Fortunately, we can determine a lot more by analyzing the waveform. Bronchospasm can be seen as a shark fin waveform. This is because the bronchoconstriction causes an increase in the time it takes to exhale, giving rise to the shark fin appearance. Here you can compare the waveforms I have mentioned so far. Using an actual printout from an ECG monitor, you can compare the heart rate, pulse oximetry, end-tidal CO2, and the respiratory rate. Notice as the respiratory rate decreases, end-tidal CO2 increases. The pulse oximetry, or SpO2, stays about the same, but the heart rate generally increases to compensate for the decreased respiratory rate. In emergency medicine, capnography has a variety of uses. For critical or intubated patients, the capnography helps with initial and continual endotracheal tube placement and conformation, assistance with difficult intubations, CPR effectiveness, return of spontaneous circulation or ROSC, monitoring of ventilatory rate, determining the etiology of cardiac arrest, code termination decisions, maximum ventilation rate for patients with increased intracranial pressure. Capnography can also be used on routine, non-intubated respiratory patients for the following types of cases: asthma or COPD, sedated or restrained patients, overdose patients, pneumonia, and anxiety. Capnography can help with the following metabolic patients: diabetic emergencies and diabetic ketoacidosis, sympathomimetic overdose such as cocaine, seizures, sepsis, hypo and hyperthermia, and gastroenteritis. We can better assess patients with circulatory emergencies, such as congestive heart failure, acute myocardial infarction, blood loss and shock, or pulmonary embolus. Research is continuing to investigate capnography's use in sepsis, acid-base balance, bioterrorism, right ventricular myocardial infarction, and advanced applications for future uses, such as increased use of metabolic disturbances and CPR termination. Let's look at some case examples. You respond to a 30-year-old female who is walking her dog on a cold winter day. Cold air can be a trigger for some asthmatics. She has used her inhaler twice without relief. She called EMS from her cell phone. Her vital signs are listed. The end-tidal CO2 waveform has a shark fin appearance. What does this waveform indicate? The end-tidal CO2 appears to be about 13 millimeters of mercury. With respiratory rate of 28 breaths per minute, a shark fin appearance, and an end-tidal CO2 of 13, we can suspect their work of breathing is greatly increased. We see the heart rate is 138, so the heart is attempting to compensate for the lack of oxygen. However, without rapid treatment, this patient may be in respiratory failure and in need of intubation. As we follow this case, the following waveform is 2 minutes after starting an albuterol and ipratropium bromide nebulizer treatment. After 2 nebulizer treatments, you can see the improvement in the waveform. In case 2, you respond to a 68-year-old male in cardiac arrest. When you arrive, you notice the man is very large and has a thick neck. As the paramedic attempts to intubate, they have difficulty visualizing the vocal cords, but proceed with placing the endotracheal tube. When the end-tidal CO2 adapter is attached, this is the waveform. What does this indicate? This waveform indicates no CO2 is being exhaled, so either the tube is in the esophagus or there is very poor CPR being performed. The paramedic decides to withdraw the endotracheal tube, ventilate the patient with a bag valve mask, and attempts another intubation attempt. This time, with the end-tidal CO2 adapter is attached, the waveform appears like this. Throughout the resuscitation attempt, the patient regains and loses a pulse several times. You can suspect a pulse when you see the end-tidal CO2 suddenly spike to a higher level. In contrast, you can suspect a pulse has been lost when the waveform suddenly decreases. In case 3, you respond to a 76-year-old female with difficulty breathing. The patient has a history of COPD, asthma, hypertension, and she had a heart attack 2 years ago. This episode of dyspnea came on gradually and has been worsening for about 4 hours. The vital signs are as listed. An assessment of lung sounds reveals a mix of crackles and wheezing. Capnography shows this waveform. This waveform shows bronchospasm, but also indicates an increased expiratory time, indicated by the blue arrow. This patient likely needs a bronchodilator. Once the bronchodilation begins, you would expect the shark fin pattern to improve, the expiratory time to decrease, and the work of breathing to improve. In conclusion, using capnography is a simple, non-invasive tool to use when you need to know how the patient is functioning on a metabolic level. Quantitative capnography gives the clinician a numerical value for the amount of CO2 being exhaled. Qualitative capnography, or waveform capnography, gives the clinician a waveform to better evaluate the patient's ventilation and respiration. If you have any questions, feel free to contact me at my email or office phone.